Hi.
Hi, doctor.
Hello.
Good evening.
Hi. Good evening. Good evening. Can you able to look into me?
Yeah, we can hear you, sir. And we can
Background, is it okay? Background, is it okay?
Yes, the background is also okay.
Okay. So I will be sharing my screen right now with you all. Just I will look whether it's clear or not.
Yes, sir. We can see your screen as well.
Okay. I will be making this PPT mode. My slides are easily visible.
Yes, sir. Your screen is easily visible, sir.
Okay. How many participants you are expecting today?
Sundar? Sir, what were you asking, sir?
How many participants you are expecting today?
Sir, approximately around 10 to 15. I will also ask Mr. Sundar Prakashan to once confirm the number of participants as well.
Okay. Okay. So this background is okay, no? No need to do anything with the background.
No, sir. It's absolutely fine, sir.
Hello. Yeah, good evening, sir. This is Sundar, sir.
Just a minute.
Yes, sir.
Whether can you able to see my slide change?
Yes,
Hello?
sir.
Yes, sir. Yes, sir.
Yeah,
You
yeah.
can see your slide.
So everything is clear now? Network issues, my voice, clarity, everything.
Yes, sir. Everything is perfect. We can see you well. Your background is very good, and also the slides are visible, and slide is changing.
I just made an attempt to try to change the background because routinely we have been doing the same background.
No, sir. Your background is fine, sir.
Even this is my first time changing the background. So at what time shall we start off?
Sir, we'll wait for 5 minutes. Sundar, we can start by 5, right?
So
Yes, 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 5 o'clock, 5 o'clock.
completely.
Yes, sir, around 12 participants are there, sir. We will wait for another 5 minutes, sir.
Okay.
Yes, sir.
Dr. Arun, good evening. I am Dr. Kannan from Chennai.
Nice meeting you, doctor.
Best wishes for your successful oration. I was eagerly awaiting for your oration. Thank you.
Thank you, sir. Thank you.
Thank you, sir. Thank you.
Shall we start, Sundar?
Hello. Yeah, ma'am. Sir, around 14 participants came, sir. Shall we start?
Yeah, shall we start? We should start.
Yes, sir. Yes.
So we from Cipla Supracare team, sir, we welcome you, Dr. Arun, for taking a wonderful session for us. So, Dr. Arun is one of the best gastroenterologists and interventional endoscopist in Chennai. There's no need to actually introduce Dr. Arun. Everybody knows of his accolades. Doctor is currently practicing as a consultant gastroenterologist at Apollo Main Hospital, Screams Road, Chennai, and is having more than 14 years of experience in the field of medicine, GI, and hepatology. So, on behalf of Cipla Supracare team, sir, we welcome you and to take this session on the role of vasoconstrictors in refractory ascites. And we are looking forward to take back the knowledge and learn from you as well. So thank you so much, sir. So the platform is yours, sir.
Thank you, Team Cipla, to give me a wonderful opportunity to share some insight in this wonderful evening post-Christmas Day. On Sunday, we'll be discussing something about one of the most complex entity in the field of hepatology is nothing but refractory ascites. Because to tackle a refractory ascites is one of the complicated scenario, even for the best of consultants, when you're going to manage this kind of patient. Because once the patient is going to land up with evidence of refractory ascites, which means the patient is almost in end-stage liver disease. Once a patient is going to be in end-stage liver disease, there might be multiple complications, not only because of liver, it could be because of any other organs and any other system might be involved at that point of presentation. So to analyze all the proper events, how to tackle, how are you going to manage once a patient is going to develop a refractory ascites, there are huge list of protocols being tried in day-to-day. But the one final line of management is liver transplant as early as possible once a patient is going to be refractory ascites, that we should not forget at any point of time. So what is the basic message I would like to convey with you all? The role of vasoconstrictors. Is there any role which is being applicable when you're going to manage a patient with refractory? Refractory means even after maximum line of management, your symptoms and signs, if it is going to get persist for a longer duration without any signs of improvement, it's nothing but refractory ascites. So once the patient is going to land up with that kind of presentation, what is your area of approach? To take on with that, a brief snapshot view now. So before taking on the main area of discussion, as to brush up your knowledge in the basics, though, what do you mean by cirrhosis is nothing but once the liver architecture, it is going to get completely disrupted and disruption is going to get taken over by your hepatic fibrosis is going to get established, formation of regenerative nodules is going to get set in. That's nothing but cirrhotic background. So usually there are multiple etiological factors for cirrhosis. If you're going to look into that in Indian scenario, right from your pediatric population, right from neonatal stages, right from older patients and adults, there are so many etiological factors for you to think about cirrhosis. But in Indian scenario, considering adult population, the most common etiological process will be alcoholic liver disease to take on, because around 30 to 40% of the patients in India will be having alcoholic liver disease. And next to that, we need to look for the most common chronic viral events, nothing but hepatitis B and C. And there are so many other etiological factors like your inborn or metabolism, your metabolic liver condition, so many other etiological factors for you to think about this. And now one highly immune is being and there is one important entity which is initially been spread over in the Western countries. Now it has been taken over in our Indian scenario, is nothing but a non-alcoholic fatty liver disease. We are now supposed to forget, even after your multiple workup, if you're not going to get the diagnosis, it's nothing but kindly mute your system, please, if you're going to be that. So basic natural history for the patient. How the patient
بص يا باشا كلهم يومين تفاعل المحاضرات اليومين دول فيكس على كل
disrupting.
لا المفروض ان شاء الله باذن الله هينزل الجدول دي يوم السبت ان شاء الله باذن الله في الجدول بكل.
Okay. So to take on with the natural history of patients who is going to be chronic hepatitis, see if you're going to look into that, how the time progress, as time progresses, how the event is take
بالظبط.
normal liver from a normal liver to fatty liver, from fatty liver for fibrotic state to chronic hepatitis, and from that to fibrotic and cirrhotic, and from that to carcinoma.
ان هم
If you're
كلهم
going to look into
يجوا
that,
يومين
so it might be
دول علشان المحاضرات بتاعت الكليه فهي كلهم يومين.
so
بالنسبه
Simran,
للتدريب
why don't you make the
موجودين عندك
participants
موجودين عندك في تدريب لان انت
some background disturbance going on?
كمان في كليه الطب هو المستشفى النمط في الطب، انما اللي بره بقى اللي بره المستشفى ده اللي هم موجودين في المعادي والجلاء وكده ليهم يوم ثالث يجوا لك فيه للتدريب.
I think I muted them. So please make yourself comfortable when you're going to be here. And next to that, the most important thing, what I'm supposed to say, that a normal liver, chronic hepatitis, cirrhosis, how is going to get progress. And if you're going to see that scenario, a normal liver, if it is going to be around 50 to 60% of the population can go for chronicity, and in chronic patients, it can go around 20 to 30% can go for cirrhotic background. And once a patient is going to cancer, there is high possibility for you to develop around 1 to 5% of the population can land up with hepatocellular carcinoma. And from that, end-stage liver disease is always to 2.5% per year, 2 to 5% per year. As the day progresses for around 20 to 25 years, and from 25 to 30 years of time, over a period of duration, that this kind of events make progress because of your B, also because of your C. There are so many natural history for you to consider that. So basically, if you want to classify this cirrhosis by compensation, means the patient is not going to develop any ascites, not going to develop any other system involvement, not going to have any evidence of massive bleed, or not going to develop any portal systemic encephalopathy. So it's mainly nothing but compensated, not much of complications. Once a patient is going to land up with complications like your renal complication, your ascitic state, once a patient is going to develop your varicose bleed, your patient is going to develop hepatic encephalopathy, that's pointer in the background of portal hypertension. Once the hepatic synthetic function is going to come down, that phase is nothing but a decompensated cirrhosis. So how are you going to classify this cirrhosis? As the day progresses from compensated to decompensated, the mortality event will be going up to 20%, and initial phase, if the patient is not going to have any esophageal varices, the mortality only will be up to around 1%. Once the patient is going for decompensation, which means the mortality is going to be around 50 to 60% of the population. There is high propensity for this kind of events to set in as the day progresses. This is how the cirrhosis is going to get evolved based upon your varied etiological factors. How are you going to approach a patient? If these things we are not supposed to forget when you're going to manage a patient with cirrhosis. And major complications like your varicose bleed, ascites, hepatorenal and hepatopulmonary, and along with your spontaneous bacterial peritonitis, your cardiomyopathy, encephalopathy, along with hepatocellular cancer, and then your portal vein thrombosis. There are multiple line of complications. There are huge armamentarium is there in the complications when you're going to look for in the background of cirrhosis. So how are you going to tackle a patient with refractory ascites? Briefly, we'll be starting our discussion with a case snippet. What I would like to share with you all, in a 50-year-old male who just presented to us with evidence of NASH related, nothing but non-alcoholic state of hepatitis related cirrhosis, with evidence of decompensation in the background of MELD sodium, which is going to be around 22. The patient has been on frequent large volume paracentesis. See, this kind of scenario will be, you'll be getting even if a physician or surgeon, if you're basic practitioner, even if you're DM consultants, when you're going to see this kind of patients in your routine scenario, whether the patient deserves hospitalization or non-hospitalization, whether the patient is sick or not sick, current one scenario, and once a patient is going to require large volume paracentesis. What do you mean by this large volume paracentesis? If the patient's ascitic fluid, if you're going to remove at least around 4 to 5 liters, more than 5 liters of fluid, if it is going to remove from your abdominal cavity, it's nothing but a large volume paracentesis. So once a patient is going to be having frequent large volume paracentesis, that shows evidence of your clinical scenario, even with your maximum line of drug treatment, if it is not going to get improvement, that shows the evidence of refractory ascites is going to take on, and multiple patients will be landing up with this kind of presentation as the day goes on if you're not going to manage in a right proportion of time. So this patient on frequent large volume paracentesis on diuretics with worsening of creatinine. Once you're going to induce a patient with diuretic support, you need to assess the creatinine and other parameters. There's so much of diuretic induced complications may develop if the patient is going to be on long-term diuretics. And this patient shows evidence of worsening of creatinine as BP is almost 90/60, which is almost in the hypotensive range with evidence of pedal edema. And how are you going to approach once a patient, if you're going to land up in your casualty with this kind of background? That's the area for me to take on the discussion right now with you all. So the basic scenario, approach a patient with ascites before taking on a discussion with refractory ascites. You should all remember that the one important thing which we have checked in from the recent Journal of Hepatology from 2018 paper, what they mentioned that the transition from compensated to decompensated will be occurring at a rate of around 5 to 7% per year. And if you're going to look into that, the stage 0, 1, and 2. So what is the stage 0? There were two parameters has to be taken into account, one by your liver stiffness and one by your hepatic venous pressure gradient. So your liver stiffness, if it is going to be more than 15 to if it is going to be more than 15, and if it is going to be less than 20, and if your HVPG, if it is going to be more than 5, and if it is going to be less than 10, which means it's stage 0, no varices. And once a patient is going to develop your significant, clinically significant portal hypertension, which means your HVPG is almost going to be more than 10, your liver stiffness is almost going to be more than 20, and stage 2 is almost the patient is going to have established varices along with this clinical background. And when you're going to discuss about the decompensation, the first bleeding event followed by evidence of decompensation, like your volume, high volume overload status, like ascites, the second decompensation could be any organ involvement. It could be because of your hepatic incurve, or it could be because of renal shutdown, multiple other complications. At the end stage, the patient is going to land up with refractory ascites, your persistent portal system encephalopathy, your jaundice is going to get worsened. You may have evidence of infection to get activated. The spontaneous bacterial peritonitis is one of the dangerous, dreadful prognostic condition to take on. Your renal and other organ dysfunction and cardiac dysfunction is going to take on, followed by there is high possibility for us to land up with ACLF, acute on chronic liver failure, and that's the area for the patient to land up with dreadful scenario. So basic condition, what we're going to look into the multi-stage model. If that's the initial slide, what I've been showing, the same thing. Once a patient is going for a compensated to decompensated phase, which means the patient is going to be a symptomatic phase, the survival is going to come down. And compensated phase, the median survival is almost around 12 years, and in decompensated, the survival is going to be around 2 years. As I discussed with you all, the patient, there is high possibility for you to land up with your ACLF and death to take on. Basically, before starting our discussion with your management protocol for refractory ascites, you should know something about the bacterogenesis of portal hypertension, how the liver cirrhosis is going to get established. Once a portal is going to get disrupted, the cirrhosis is going to take on, followed by the portal hypertension is going to get ensue. Follow the mechanism mainly by your splanchnic vasodilation and your systemic vasoconstriction that's going to get happen. Once the splanchnic vasodilation, if it is going to get initiated, which means your splanchnic capillary pressure is going to get raised, that shows evidence of ascitic formation. Your oncotic pressure is going to come down, your hydrostatic, even if it is going to go high, your all the vasoconstrictive pathway mechanism, if it is going to get activated, the nitric oxide pathway, once it's going to get activated, which will predispose to further splanchnic vasodilatation, your natriuretic peptide, if it is going to get released, which will further augmenting the further vasoconstrictive mechanism, which will predispose to arterial underfilling and further activation of your vasoconstrictors and antidiuretic factors, which will predispose to sodium retention, and which will further contribute to your worsening of ascites. And this vicious cycle is going to get progress as the day progresses. That's how the refractory ascites is. That's how the basic pathophysiology of your ascitic mechanism is going to take on when you're going to manage a patient with chronic liver disease. And once a portal hypertension, also always remember that when the patient is going to land up with hepatorenal syndrome, which means once a patient had minimal altered creatinine, doesn't mean that the patient is having evidence of hepatorenal syndrome in the background of cirrhosis. Always you should remember that as the day progresses, the end-stage liver disease that shows evidence of high volume renal vasoconstriction. That is the area where you need to think about your hepatorenal syndrome to get activated. And the initial phase of ascites followed by your diuretic refractory phase. And at last, at end stage, you are going to take on with HRS, hepatorenal syndrome. That's the basic thing you need to understand. Once the splanchnic vasodilatation as well as renal vasoconstriction, if it is going to get checked on, that's the area as the day progresses, your HRS is going to get ensured. This is the basic natural history of your ascitic formation. So from portal hypertension, no ascitic phase to your HRS at the end stage of liver disease, how it is going to get augmented. And once the HVPG, if it is going to be less than 10 with minimal vasodilatation, no major ascites. If the HVPG, if it is going to be more than 10 with extreme vasodilatation, followed by uncomplicated to refractory ascites. And once the patient is going to take on with refractory, there is high possibility for the patient to land up with hepatorenal syndrome. This is basic approach, the basic knowledge. We should not forget how it is going to treat a patient with ascites. One thing, we need to look for the cause, look for the etiological trigger. Not all ascites is because of liver-related pathology. We need to look for the cause. There are multiple etiological factors for you to take on, discuss with ascites. That's not the area for discussion right now, but we need to analyze the cause. We need to think whether it's because of liver and other factors is going to get involved. Once a cause is going to get strongly established, we need to look for whether it is high protein, high SAG or low SAG ascites, whether it is going to be high SAG. And if it is going to be high SAG means if your SAG, if it is going to be more than 1.1, that shows evidence of portal hypertension around more than 90 to 95% of the population is strongly to be established, which shows that the patient is having evidence of chronic liver disease. So we need to look for the etiological possibilities like your alcohol, it could be because of viral, so many etiological triggers are there. The most important thing, once a patient is going to land up with ascites, we need to look for the treatable causes like alcohol means you need to stop. If the patient is going to land up with hepatitis B or C, either genophobia and chicavi can be taken on, and along with your C management, direct antivirals, all those things to be initiated right proportion of time with evidence of control of portal hypertension protocol, all those things to be managed. And we need to identify any precipitating factors for that. For example, if you're going to land up with your major GI bleed, that itself will allow a further decompensation in the phase with the patient is going to land up with evidence of hepatic NCOV. And next to that, once the patient is going to be a dietary indiscretion or a diuretic non-compliance, if the patient is going to have evidence of hepatocellular carcinoma in the background with or without portal vein thrombosis, and if they're going to have any drug abuse like your usage of NSAIDs, which is going to be there for a longer duration, these are all the precipitating factors you need to look into that when you're going to manage a patient with ascites. And if it is there, you need to strongly eliminate those triggers. And you need to do a basic sodium restriction. You need to maintain a salt intake of less than 4 to 5 grams per day, and sodium intake should not go more than 2,000 milligrams. And your low salt diet alone is the high possibility for the ascites to come down around 10% of the population if you're going to treat only with your salt restriction pattern. And diuretics, when you're going to use, most of the time we need to go for an anti-androsteronic molecule. It's nothing but spironolactone to start with, and always in case we can combine with a loop diuretic, because when you're going to combine the potassium sparing with your loop diuretic, what is going to happen? That shows major advantage because it shows a greater and faster effect on urinary sodium excretion, and also it will be acting on your various tubular sites. And next to that, there might be possibility of worsening of hyperkalemia will be less when you're going to use your loop as well as your potassium sparing diuretic. So always combining with the loop and potassium sparing is most important when you're going to manage a patient with diuretics. And how are you going to step up and how are you going to step down? That's the progresses we need to analyze based upon the clinical response that I'll be discussing. And basic adverse events for spironolactone because of aldosterone, we need to remember there's nothing but a gynecomastia, and we can start from basic 40 milligrams of furosemide along with the basic, we can go up to maximum dose of around 160 milligrams of furosemide, and we can go up to maximum of 400 milligrams of potassium sparing diuretic we can try when you're going to manage a patient with ascites. So our target, once you're going to start the protocol of management of ascites, you need to target your urinary sodium excretion. your urinary sodium excretion should be more than 78 millimoles, which means nothing but when you're going to look for your spot sodium urine spot urine sodium and potassium ratio, it has to be more than 1, which indicates a 24-hour urinary sodium excretion almost more than 78 millimoles. And we need to maintain a strong negative nitrogen sodium balance with weight loss has to be strongly established of around 0.5 kg per day, which more in patients with peripheral edema. So if this thing is not going to happen, then you need to increase the dose of diuretics after 3 days if the response is not going to be adequate. So the basic definition for your refractory ascites, if the ascites, if it is not going to get mobilized or if it is going to get recur as early as possible. And there are 2 basic definitions in the management of refractory ascites, even after large volume paracentesis and even after maximal diuresis, diuretic support for around 160 milligrams of furosemide and 400 milligrams of spironolactone. Even after that, if it's not going to get a response, then the refractory ascites can be categorized into 2 major events, nothing but one is because of diuretic resistance and another one is because of diuretic intractable. Diuretic resistant means even after maximal dose, if it is not going to improve, the response is coming down, nothing but diuretic resistant. But diuretic intractable means if the patient is going to land up with any complications when you're going to use your diuretics, you may develop electrolyte disturbances, you may have evidence of hyperkalemia, all those things when you're going to, if it is going to precipitate you to stop the molecule, that's nothing but a diuretic intractable ascites. So we need to look for the possible events, whether it is because of diuretic resistant or whether it is because of diuretic intractable. The basic definition, what we are checking from EASL right from basics, we need to remember that. And even after maximum, even after your diuretic therapy for at least around 1 week and on salt restriction of a diet of less than 90 millimoles per day, even with that, if the patient's symptoms is not going to get response, the patient is going to land with evidence of refractory ascites that you consider. And we need to target a mean weight loss of less than 0.8 kg over a period of 4 days. If it is not going to happen, that shows evidence of your lack of response. And when your urinary sodium output, if it is going to come less than your sodium intake, that shows evidence of refractory ascites is that to take on. And what do you mean by recidivent event of early ascitic recurrence is nothing but reappearance of your grade 2 or 3 ascites within 4 weeks of initial mobilization. That shows evidence of early ascitic recurrence has been there. And we all look for the complications, huge list of complications in the cirrhotic background when you're going to manage a patient with diuresis, whether it's because of hepatic echo, worsening of HE. And if you're going to look for the precipitating, it could be nitrogenous or it could be non-nitrogenous. That's a separate area. Hepatic encephalopathy is such a wonderful clinical scenario to diagnose and to analyze. And next to that, renal impairment, if the patient's serum creatinine is going to come high as around 2 milligrams per deciliter, even with the maximum support, and hyponatremia, if the serum sodium, if it is going to be less than 125, your hypo or hyperkalemia and incapacitating muscle cramps, if it is going to take on, that shows evidence of your diuretic complications that you analyze when you're going to manage a patient with refractory ascites. That's the basic definition what we are checking from the ASLD paper. The same thing, if you're not responding to diuresis, even after large volume paracentesis. So if your urinary sodium excretion, if it is not going to get targeted more than 78 millimoles, and you're going to develop a significant complications, that shows evidence of refractory ascites. And the medical management for a patient with refractory ascites is by, first, when you're going to tell with large volume paracentesis or medical line of therapy, and if it is fine, then we can consider tips based upon the clinical scenario. Even considering the patient with early tips sometimes will be more involved and more important due to assess your clinical response. And liver transplant, even there are other new modalities are there, but still a questionable issue whether it is applicable in India, how far it is going to be successful. And next to that, the initial phase of treatment, always you need to look for the etiological clues. If the etiological clues, address the etiological clues first. And next to that, we need to eliminate the harmful triggers. If the patient is going to be on SC inhibitors, or if the patient is going to be on ARBs, and if the patient is going to be on NSAIDs, always you need to stop it because we need to target a MAP. MAP is nothing but a dash with BP plus 135 pulse pressure. So we need to target the MAP. If the MAP, if it is going to be more than 82 millimeter of mercury, the chance of survival will be more than 2 years, 70 to 80% of the population. And if the MAP is going to come down, if it is going to be less than say 80 millimeter of mercury, it shows the 20% survival. The 2 years survival is going to come almost around approximately 20% of the population. So we need to look for that. AC inhibitors, ARBs, all those things there are high possibility for them to reduce your MAP and block the production of your all the components mechanism is going to happen once a portal hypertension is going to get checked on. So always we need to avoid using NSAID because there is high possibility for them to inhibit your prostaglandins and which will predispose to renal vasodilatation and which avoids renal vasodilatation, which will predispose to renal vasoconstriction, thereby shows evidence of lesser response to your diuretics, which will further precipitate acute kidney injury. So you always should remember that eliminate the basic triggers, stop all the alarming molecules, whatever is dreadful, and followed by we need to take on with the diet and sodium restriction as the most important thing. As a low salt diet, nothing but less than 2,000 and some latest papers up to 4 to 5 milligrams per day, we can stop no added salt, and diuretic should be permanently discontinued once a patient is going to develop intractable complications like your NCAF, renal impairment, or severe arterial disturbances. If it is going to get taken on, and you need to continue only when urinary sodium excretion, if it is going to be more than 30 millimoles per day. That's the area for diuretics to continue. And your step 3, the management of portal hypertension and ascites, your beta blockers. Always you need to start with a non-selective beta blockers for your patient to consider, but there are certain contraindications when you're going to target a patient with beta blockers, which means if the patient's systolic BP, if it is going to be less than 90, your creatinine, if it is going to be more than 1.5, your hyponatremia, if it is going to be less than 130, then you should be very cautious when you're going to use your beta blockers. But first thing, you need to start with the lower dose, and best one, if you're going to use a beta blocker like your propranolol, the best molecule to consider, you can go up to 160 milligrams per day. And carvedilol also you can consider, but one problem with carvedilol, it shows evidence of alpha blockade also, that shows evidence of your vasodilatory mechanisms, which means the concept is slightly coming down when you're going to use the potential beneficial role is coming down. So the possibility, the more is propranolol rather than with carvedilol in the background of hypertension to continue in this background of refractory ascites. So we need to maintain a target heart rate of around 52, which cannot be, most of the time will be strictly followed as per the norms. And next to that, what is the role, the most important area for us to lead on with the discussion right now is your oral midodrine. There's nothing but your alpha agonist. So the various mechanism of action is nothing but what is going to happen if this is going to improve your mean arterial pressure. It's going to improve your blood pressure in advanced cirrhosis, which is going to improve your renal perfusion. So we can use midodrine in patients with hypertension and or diuretic resistance who do not respond to dietary modifications, all those things. And we can start by 5 milligrams. We can go even up to 17.5 milligrams. And a huge list of the one best of paper by Professor Virendra from PG Chandigarh, what been discussed. And there are so many areas for this paper taking on with you all in my upcoming slide of discussion. Next to that, the basic pharmacological areas to brush up on knowledge in midodrine. It's mainly the metabolism is going to get happen in your liver, and it's going to convert into active metabolism, what you call as desglycomidodrine. And next to that, the concentration, the half-life will be approximately around 1 hour, and the distribution and all those things. The elimination will be predominantly by insignificant renal elimination. The metabolism is mainly by liver, and the actual metabolic we are not supposed to get forget. And in this mechanism, what is supposed to remember, the alpha-1 agonist, what is going to happen? It is going to improve your vascular tone, and it's going to elevate your BP. Once the BP, if it is going to get augmented, that shows evidence of vasoconstriction. Your splanchnic vasoconstriction is going to check on. Once the splanchnic vasoconstriction happens, which means it's going to improve your systemic circulation. Once the systemic circulation is going to get improved, the renal function is going to get improved, which will increase your water as well as your sodium excretion, which improvement of acidity. This is one important thing when you're going to remember, and when you're going to use midodrine, which is going to enhance your sodium as well as your water excretion, thereby evidence of your improvement of your acidity. So the dosage, what have been discussed, as at an incremental dosage from 5 milligrams every 24 hours, even up to 17.5 milligrams we can consider, but as per the various trials, what we mentioned, So we can go maximum up to 10 milligrams in various papers what they've been quoted, and some papers can be tried even up to 12.5. There are a few studies even up to 17.5. I have seen more studies of being there. But only thing, when you're going to use midodrine, we need to use an administration interval of around 3 to 4 hours immediately after rising in the morning and midday and also in the evening, at least 4 hours before bedtime, to prevent the risk of your supine hypertension, which is going to get happen. And midodrine in refractory ascites, this is the recent paper from EAS, what you're going to Professor Virendra, what you've been saying that. So if you're going to take around 40 cirrhotic patient, when you're going to use your midodrine along with your standard medical therapy, what is it? Standard medical therapy is nothing but you need to restrict your sodium, we need to treat the patient with diuretics, and we need to go for repeated large volume paracentesis along with evidence of albumin support for every liter. But that's what we'll be discussing. So albumin, sodium, as well as your diuretic with your large volume paracentesis, which is nothing but your standard medical line. And in this line, we are going to add midodrine almost around 7.5 milligrams by Professor Virendra twice daily, which shows a significant beneficial role when you are going to use midodrine in refractory ascites. That's what the paper been shown your clinical outcomes and survival in patient with refractory ascites. It used to be considered. So main thing, it's going to increase your urine volume, your urine sodium, and your MAP and survival. That's how it's going to get act on. This is nothing but your short-term use of your short-term usage of midodrine. If you're going to use your midodrine for almost around 7 days, it's going to improve your systemic hemodynamics as well as your sodium excretion, even in your non-azertemic population, non-azertemic cirrhotic patients, even if the patient is not going to have with or without ascites. So that shows evidence of midodrine to improve, to augment your systemic hemodynamics as per the various trials, various papers is being quoted here. And in this paper, what they mentioned that once you're going to use midodrine, that shows evidence of your renal hemodynamics, renal function, and how your hormonal measurements going to get happen in patient without hepatorenal syndrome. So if you're going to use the first 3-hour period after midodrine, a significant MAP increase, a systemic vascular resistance, and a significant decrease of your heart rate and cardiac index has been observed, and changes of MAP and heart rate was still significant during the second 3-hour period. So what they've been trying to say, administration of midodrine, if you're going to look into the hormonal measurements, was almost observed a significant decrease in your plasma renin activity. If you're going to see why, because your plasma renin is one thing which is going to get augmented in your PICD, nothing but paracentesis induced circulatory dysfunction. So that's the area you need to measure. Your marked decrease in PRA as well as your serum nitric oxide, and along with antidiuretic hormone. And next, there are no major changes being observed in anti-natriuretic peptide or your plasma aldosterone levels when you're going to use midodrine. So is there any papers to look for the beneficial role of when you're going to combine your midodrine with your octreotide in refractory ascites? Both midodrine and octreotide can reduce your plasma renin activity, but midodrine can reduce PRA, and also it can improve your GFR more potentially than your octreotide. And there are newer papers, newer trials being tried with your midodrine. If you're going to use almost around 7.5 milligrams 8 hourly in the background of refractory ascites, and you're going to combine with your clonidine, which is almost around 0.1 milligrams 12 hourly, which shows midodrine in combination of clonidine can be tried along with your standard medical therapy, but doesn't mean that clonidine plus standard medical therapy doesn't show to have any significant beneficial effect rather than combining with the midodrine based support. So there are various newer therapies being tried, and midodrine, when you're going to combine with your V2, when you're going to combine with your 12-Vactan, is nothing but, so when you're going to use the rapid control of ascites is going to be there compared to midodrine or 12-Vactan alone. So if you're going to look into this, the standard medical therapy plus 12-Vactan is not going to match a beneficial midodrine, but you're going to use standard medical therapy with the midodrine and 12-Vactan combination shows to have a significant beneficial effect in controlling your ascites. And the newer therapy like citalopram, your V2 receptor antagonist, which is predominantly being acting in your distal tubule distal tubule of your kidney to enhance your solid-free water excretion. So what is going to happen in this paper, or 110 population being studied, when you're going to use citalopram, the significant beneficial role as proven by Wong and Gangs et al. Whatever mentioned, that significant beneficial role is not being well documented when you're going to use a new molecule. So the questionable issue of baptans still to be considered when you're with refractory ascites along with your midodrine. And in this paper, the various months, when you're going to use at month 1 and month 3 and month 6 of your refractory ascites, when you're going to use midodrine with your child medical therapy, well, how the patient is going to respond, that's the area for us to discuss. We need to see whether the patient is going to a complete or partial, or there is no response. The complete response is nothing but that patient shows complete elimination of your ascites, is very characteristic presentation. And the partial response, the ascites is still there, but the patient doesn't require much of paracentesis. And the absence of response, which means the ascites, if it is going to get persistent, the patient requires frequent, which means the response not there, and you're going to use this. So it shows a reasonable response with the complete response. Almost, if you're going to look into the midodrine group, it shows a reasonable response when you're not going to use midodrine. So that's how the midodrine is going to have a beneficial role in refractory ascites. It's going to improve your mean arterial pressure. It's going to decrease your cardiac output. It's going to improve your systemic vascular resistance, and urine output and urinary sodium is going to get augmented. And your PRA, which is one of the dreadful things, which is going to be there in PICD, which is going to come down. And next to that, your renal or hepatic dysfunction will not be there. If you're going to that's an area we need to tackle when you're going to address the patient with midodrine in the management of patient with refractory ascites. So, is there any paper required for the beneficial role when you're going to combine your midodrine with your rifaximin? Yes, that shows some evident beneficial effect, but there are not much of paper to trial in this area, so nothing much to discuss. But this paper, what they've been shown that the rifaximin and midodrine, when you're going to add with diuretics in difficult to treat ascitic group, it's going to improve your renal as well as your systemic hemodynamic and your short-term survival, and should be included in the management of patients. So you can add your rifaximin, no doubt about that, even for your hepatic NCAF and other things when you're going to tackle a patient with that. And this important paper is very important. It has been taken from 2018 of Journal of Hepatology. When you're going to use your midodrine with albumin for the prevention of complications in patients with cirrhosis who awaits liver transplants, very important randomized trial. See, in this paper, what they mentioned, how long you're going to use midodrine. The long-term usage of midodrine can be more useful for the shorter duration in terms of improvement of renal perfusion as well as the sodium excretion. So when you're going to use midodrine for a longer duration of time, it shows definite beneficial role to improve renal as well as your renal perfusion as well as your sodium excretion. So to highlight the main areas, the circulatory dysfunction is one of the most characteristic areas of presentation. We need to improve our circulatory functions, and we need to target with the oral vasoconstrictors like midodrine along with your albumin support in the management of refractory ascites. Or midodrine plus albumin is going to decrease your renin as well as your aldosterone levels. However, midodrine plus albumin did not prevent complications and was not going to improve your survival overall unless and otherwise the patient is going to tackle early. So midodrine is almost not going to be inferior with your albumin when you're going to tackle your renal function, sodium as well as your 24-hour urinary sodium excretion, and but no significant difference, long-term usage. But options of the initial treatment, what are the things you need to address is your large volume paracentesis, your TIPS and liver transplant. This is one important thing what I want to discuss with your large volume paracentesis. What is this? When you're going to do a tap of almost 5 liters of fluid, it is going to get removed. And for example, when you're going to remove around 10 liters of fluid, this for example scenario, every 2 weeks when you're going to do, and for this is going to remove 1,300 millimoles of sodium. You just think that on almost patient who is going to consume 88 millimoles of sodium per day, who is going to excrete only 10 millimoles non-urinary sodium, which means is almost going to retain around 78 millimoles of sodium per day. Therefore, even after 10 liters of paracentesis, which is going to remove your 17 days of retained sodium in patients with no urinary sodium in a fraction of a second. So you should remember that that's the area of large volume paracentesis patient. So we need to target a spot urine sodium potassium. Urine sodium by potassium ratio should be more than 10, which means it indicates a 24-hour sodium excretion has to be more than 78 millimoles when you're going to use a patient with diuretic support. So albumin always very important. We need to give around 6 to 8 grams per liter of albumin. 6 to 8 grams of albumin per liter of acidic fluid removal. And as per how many liters of fluid if you're going to remove, we need to target your albumin support. And as per answer trial, so many papers are there to report the beneficial effects of long-term albumin support when you're going to look into that. And always albumin infused during and after shortly after the paracentesis is most important. And terlipressin at the initiation when you're going to use at 1 milligram of paracentesis, 1 milligram at onset of paracentesis, and 1 milligram at 8 hours, and 1 milligram at 6 hours, and midodrine along with that may be as effective as albumin, can be considered when you're going to manage a patient with refractory ascites, but of all the cause and other things to be addressed. So this is what being taken from your answer trial for long-term usage of albumin in your standard medical treatment group. So what has been mentioned that long-term albumin administration in patient with decompensated cirrhosis, what they've been mentioning there. So if you're going to use almost around 40 grams twice weekly for 2 weeks, and then 40 grams weekly for up to 18 months, it shows the overall survival for a period of 18 months along with standard medical therapy. It's going to be definitely high when you're going to use albumin for a longer duration than using only SMT alone. So always you should be thinking that, you should remember that as per answer trial, combined long-term albumin support is going to have a significant beneficial role. And before we're going to take on a conclusion, we need to remember certain things about your PICD, paracentesis induced circulatory dysfunction. Whenever you're going to take on with your large volume paracentesis, is going to happen around 80 to 30% of the population, which means the hemodynamic alteration is going to set in. As I discussed with you, your plasma inactivity is going to be targeted high, along with which causes your hypovolemia as well as your aldosterone levels is going to go high, your ADH activity is going to come down, your systemic vascular resistance is going to come down, and followed by your eventually it's going to lead up in your impaired renal perfusion and renal failure is going to take on. So anytime within a period of around 6 days that after large volume paracentesis, you may develop evidence of paracentesis induced circulatory dysfunction, which is rapidly fatal. And nowadays you need to it shows there can be rapid recurrence of your ascitic fluid as well as your renal failure, hyponatremia, and your rapid detrimental in your survival rate will be there once the patient is going to take on with your PICD. So what is the role of terlipressin? Terlipressin with albumin paracentesis induced circulatory dysfunction. If you're going to use, see, both terlipressin and albumin prevented paracentesis induced renal impairment. So terlipressin may be as effective as albumin in PICD, but what they mentioned in you're going to use midodrine may not be much of role, because if you're going to see in PICD patient with midodrine and 30% of the population with PICD is going to develop in almost 60% of the patients in midodrine and almost around 30% of the population with albumin group. So midodrine is definitely not as effective as your albumin in your PICD. So role of midodrine is still a questionable issue once a patient is going to land up with PICD. So paracentesis induced circulatory dysfunction, and you're going to use your volume expanders like your albumin, dextrin, polygallin. If you're not going to expand the volume, which means the 75% of the population is going to have worsening of events. And once a patient is going to have albumin support, which shows evidence that only 15% is going to have evidence of worsening of your PICD, which means the albumin is going to have a significant beneficial role in PICD. And apart from that, few ideas about your tips and other things, we can go with the minimal size to prevent your refractory ascites. Once a patient is going to land up with early management, some centers are being initiated with the tips. We can go by 6 mm strand, we can go by 8 mm, and we can go by 10 mm. The various studies are there, but tips is one thing, nothing but transjugular intrahepatic portosystemic shunt, which is going to place between a shunt between your hepatic as well as your systemic venous circulation, portal and hepatic system. So what is going to happen that shows evidence of highly effective treatment, but the possibility of hepatic encephalopathy is still high when you're going to go for early tips, and it may precipitate your heart failure. And tips should be considered for patients who require frequent paracentesis. As I discussed with you, the initial MEL is originally developed to prevent survival after your tips insertion. So this is the basic outline. Your stent has been placed between your hepatic as well as your portal system. And next to that, The other line of management in which your urine, your fluid from the peritoneal cavity, if it is going to drain into your urinary bladder, is nothing but alpha pump. It's nothing but a battery-driven system. If you're going to place a subcutaneously implanted device, which is going to get driven by a battery, what is going to get happen? That shows that alpha pump is going to get involved. But in now India, as of now, these are very costly, costly affair, which is most of the time it's difficult to initiate, but you can drain large volume of fluid into your urinary bladder to excrete as urine. And this is how the alpha pump mechanism is there to take on. And there are multiple studies, but the septicemia, other things, the papers are there to report. Nothing much on this area to discuss. Apart from the peritoneal dialysis, your Plurex catheter are there to address this refractory ascitic management protocol. But basically, you need to remember this important paper, what I would like to quote from your PGH Chandigarh article, what they mentioned in that. Once a patient is being developed with the evidence of cirrhosis with ascites, who is not going to respond to a usual measure, we need to address major conditions. We need to do a diagnostic tab, look for evidence of any spontaneous bacterial peritonitis, look for evidence of tuberculosis, and always you need to see your ADL level. Sometimes your coexisting other infections could be, and you need to look for your 24 hours urinary sodium, spot sodium, potassium ratio has to be more than 1 in order to show that the diuretic is reasonably functioning. And next to that, if it is not there, eliminate the diet sodium, eliminate the triggers, stop alcohol, and drug-induced, and like NSAID is alpha, ARBs, AC inhibitors, look for the etiological triggers. If alcohol, if cancer, try to treat the primary condition, and we can go for large volume paracentesis with albumin support, what I've been discussed with your answer trend, and there shows evidence of MAP, nothing but your diastolic BP or one that of pulse pressure. We need to target your MAP more than 5 to 10 millimeter of mercury about your baseline levels. And so what's the most thing we can consider MAP? Midodrine if the patient is going to have low MAP, or we can go for tips also. If nothing is going to work on, we can ask for aspirin, we can consider long-term support every 2 weeks for almost a period of 48 weeks. We can consider albumin, long-term albumin.
Before your leg will become like that too. Your leg will become like that too.
How?
In your mouth. Which side?
Is a patient
Up or down?
Down.
So kindly mute. And if nothing works on, we need to consider the patient for liver transplant as early as possible when you're going to manage a patient with refractory ascites. So tackling a chronic liver disease is one of the toughest issues. To diagnose the events is another toughest issue, and to address the management protocol in refractory ascites is to be strongly established, and to whom we need to refer, to which center we need to refer. And that's the most important thing when you're going to address and when you're going to treat a patient with refractory ascites with midodrine. Even we can go up to a longer duration and other things, but correctly documentation, correct identification of the patient with refractory ascites to look for evidence of diuretic resistant or diuretic intractable complications. The most important thing when you're going to manage a patient with chronic liver disease induced refractory ascites. Thank you very much for your patient listening. With this, I would like to rest my presentation, and I'm happy to take up your questions if anything is there to take on. Thanking you all.
Hello. Yes, sir. Thank you, sir. Thank you for a wonderful space, sir. Sir, there is a few questions from the audience. Shall we move on, sir?
Yes, please.
Yeah. Number one question is, how long midodrine can be used in HRS, sir?
So good question. Actually, if you're going to use midodrine, we can go almost up to, there are some papers being quoted even up to 3 months. Some papers are being quoted even up to 6 months. Some papers up to 12 months. And there are some centers being tried for 18 months. There are some centers being tried even up to liver transplant. So based upon your clinical experience, but my experience has gone almost around up to 1 year when I'm going to manage a patient with midodrine along in the background of refractory ascites, and we need to strongly establish a clinical protocol, and we need to consider the patient to progress for as a liver transplant is most important thing. So depends upon the clinical scenario, but the one thing which has to be strongly addressed in midodrine, there are so many pharma agents being available, but one thing when you're going to think the cost of the cost, all those things, constraints are still being there when you're going to use midodrine. You can start by 2.5 and we can go up to 5, and we can go up to 7.5 also. And I've gone up to 10 milligrams in some patients, but how far it's going to be successful, not only midodrine, you need to consider other molecules when you're going to use for refractory ascites.
Yes, thank you, sir. And one more question is, how common is fatty liver to reach development of cirrhosis, sir?
Fatty liver, there is high possibility for us to be developed cirrhosis, because as we all know, fatty liver disease is one of the commonest contributor for us to land up with cirrhotic background, because even if you're going to take alcohol, there is around 90 to 100% of the population is going to land up with fatty liver. And you're going to remember that the fatty liver is non-alcoholic fatty liver disease. It is going to be there once a patient is going for steatosis, the possibility of fibrosis, cirrhosis, and hepatocellular carcinoma. There is high possibility for the patients to land on. So once a patient is going to have fatty liver, you need to do a strong diet and lifestyle modification, which is one of the most important thing, and your exercising factors that I've been discussing in my multiple presentations in previous events, what's been happening in NAFLD. So you should remember that fatty liver always is one of the alarming events to diagnose early. Your risk factor, your progression of events based upon your other coinciding and coexisting comorbidity. Based upon all those things, you need to diagnose whether the possibility of fatty liver to land up with cirrhosis is high or not.
Yes, sir. Then next question is, what is the maximum dose of midodrine can be tried?
I think I've answered in my previous papers the maximum dose. We can start from 2.5 and 5 and almost around 7.5 to 10. And some papers have been quoted almost around 17.5 milligrams also can be tried. But how far is going to be beneficial? My experience with those areas is slightly low, and I have been tried up to 10 milligrams. We can go up to 17.5 based upon various papers and various centers being tried about.
Yes, sir. And one more question from Dr. N. Kannan. And before going to the question, and Dr. N. Kannan applauded you also, sir. There is a very elegant and informative talk, sir. And most of the diabetic patients will have NAFLD, and any message on inhibiting the progression of NAS and further chronic liver disease, sir?
It's a good question, Dr. Karan. So it's for you from your side. So what I would like to state in that, once a patient is going to land up with this kind of NASH, NASH is nothing but it's a histological pointer. Once a patient is going to have worsening of your liver function, your liver synthetic factors, if it is going to come down, and all those things, acute hepatological event, acute worsening, even if it is going to take on, nothing but your NASH state is going to be there. Once the patient is going to develop NASH, the possibility of the patient to develop a non-alcoholic fatty liver disease, the possibility of the patient to land up with cirrhosis is slightly high. So we need to manage any NASH patient as per depends upon the hospitalization protocol is needed or not. And all the patients, we need to augment a strong diet and lifestyle modification. And some medications have been still being tried. Multiple papers with role of vitamin E, multiple papers with role of obituric acid, so many other molecules being there in the armamentarium to think about this NASH protocol. But once a patient is going to develop NASH and other complications, NAFLD, the mortality is definitely going to be high. That has to be strongly addressed when you're going to manage a patient with this kind of scenario.
Yes, and one more question is that how to diagnose PICD, sir?
PICD, as I discussed with you, paracentesis is your circulatory dysfunction. If you are having any reason history of large volume paracentesis, if your MAP is not going to well maintained, and if your hemodynamic outpatient is going to be there along in the background, if the patient is going to have evidence of plasma rain, if you're going to look into that, if the activity is going to be more than 4 nanograms, that shows evidence that the patient is going to land up with evidence of PICG. So you need to be having a take-home alarming measure when you're going to manage this kind of scenario.
Yes, sir. That was the question from the audience, sir. And only one question from my side, sir. Actually, this as we discussed regarding about midodrine also. Then how do you see these molecules, this midodrine in case of HRS or refractory acid? And what about the future of the drug? Any developments are there in terms of the HRS and RA? Is this midodrine and
has been looking into the molecule initially. Midodrine has come around 30 packs, and now it's been coming even in 10 tablet strips. All these things being available, but midodrine alone is not going to have a significant beneficial role in the management of refractory ascites as well as your hepatorenal syndrome for us to take on the discussion. But midodrine, when you're going to combine, as I discussed, with your standard medical line of treatment, along with your diet, lifestyle modification, dietary elimination, your sodium restriction, along with your large volume paracentesis, along with your albumin support, and you're going to consider all those things, how far it is going to be established if the patient is is poor, almost all the constraints still there. Albumin is very costly molecule, costly affair. How are you going to use that for a longer duration? So all those things has to be addressed, that too in a poor country like ours, and that in poor country like ours. So we need to look into all those things when you're going to manage a patient, because the cost of treatment is definitely going to be high. And the most of the time when you're going to manage a patient with midodrine alone is definitely not going to have a significant beneficial effect. And you need to combine with multiple line of molecules in managing a patient with refractory ascites as well as hepatorenal syndrome, and treating the patient, analyzing the concepts, and refer the patient promptly to the hepatologist, to a higher liver transplant center is the most important scenario when you're going to address this. Anything else?
Hello. Yes, sir. Yes, that was the questions from the audience, sir. And really, thank you thank you for your presence in this meeting, and thank you for making this meeting wonderful, sir. And thank you for valuable time given to us, and for disseminating the knowledge to all the audience also, sir. And thank you all the participants also who have joined this meeting. And during this Sunday, I think in between 5 to 6, it was in a busy hours on that. And thank you all the doctors also who have joined. And thank you, Dr. N. Arun also, so on behalf of C+. Thank you, sir.
Thank you, Cipla team. Thank you for all the participants being here. Thank you all.